So we are adding some fluid. I mean, the blood that we transfuse does have fluid in it, but many times what we give as a blood transfusion is what we call packed red blood cells. We've already removed a lot of the fluid. We've just left enough so it still flows easy. So somebody other than Teresa, so Teresa, hold on for now. Why would a packed red blood cell blood transfusion lead to hypervolemia? I can almost hear you. Say it a little bit louder or have your instructor repeat it for me.
She said too much electrolytes that we're adding in the other stuff.
Okay. Again, if that person's blood was balanced in their electrolytes when they donated that blood, then the electrolytes probably aren't going to be an issue, right? So there's something else in there that is of concern. Enid, do you want to jump in and help them out?
Why with red packed red blood cells, why does it make people
Because
happy?
there's more switched into smaller volume, or
Increased blood volume.
highly concentrated, they said.
Okay, but what's concentrated? What's going to change the fluid status for the patient? If we're not giving them a lot of fluid to begin with, it's concentrated. Why are they getting hypervolemic?
Because there's increased blood volume.
Increased blood volume. We're talking in circles and helping you walk better.
All right, I'm gonna add another person in the conversation. Stillwater, any ideas? Yes, I can repeat the question. All right, so why does giving somebody a packed red blood cell transfusion, so we've removed most of the plasma out of it, we've left enough so it's still transfused. Why does that lead to the risk of hypervolemia for a lot of patients?
It has too much of the sedative, like you have the water component, then you have the concentrate component. Now they've got too much concentrate component, not enough of the water volume.
What's the concentrate component you're talking about?
The solutes, what is it?
What's in it? What's in
It's
those?
not the plasma, it's the,
You're talking, you're getting really close. Somebody said it's something.
hematocrit?
What makes up the hematocrit?
No.
What's up the
Red
hematocrit?
blood cells?
The red blood cells. What are red blood cells, white blood cells, platelets made out of?
Protein.
What does protein generate in the vascular space? Oncotic pressure. So remember, that person who gets the blood transfusion, they are already anemic or hypovolemic, meaning that they have a less than normal blood volume. So if they are anemic, the fluid in the vascular space may be hanging out in the interstitial space because they didn't have enough red blood cells, enough protein to begin with, and it leaked out into those peripheral tissues. We start putting those back in there. We give them a power surge of protein through red blood cells, white blood cells, platelets, and all of a sudden, all that fluid that's hanging out in the tissue begins to be reabsorbed into their vascular space to make it the right concentration. And that's how those people get into hypervolemia. And it can happen even by the time you finish transfusing the first unit, depending on their overall state of health. So many times, you'll learn about this in adult 2, when we give a blood transfusion, we follow it with a dose of diuretic, because we know that fluid shift is going to happen, and we don't want to put them into hypervolemia. We're simply trying to get them where they're not anemic anymore.
Mr. Baird,
Yes.
it's Mrs. Hagen talking. Can you kind of give us a quick recap on that? There was a whole lot going on in our room and we didn't all follow that.
Okay, I will. So remember, the primary reason we give blood is because the person is anemic or the person has had a hemorrhage or a blood loss event. If they are anemic, that occurs gradually over time, and the fluid in the vascular space is going to leak out and generate peripheral edema. It's going to go out into the interstitial space and get trapped because there's not enough proteins, not enough oncotic pressure in that bloodstream to hold it there. So people who are anemic often present with puffy legs and maybe even fluid in their lungs. We hear it as crackles, okay? When we replace those proteins quickly through a blood transfusion, all of a sudden we change that person's oncotic pressure over the course of that transfusion, and all of that fluid that was hanging out in the tissues begins to be reabsorbed into the vascular space to make it the right concentration again. And that's how they get into hypervolemia. So when we give a blood transfusion, not the first unit, it will almost always be after the second and the third or fourth unit, we will give a dose of diuretic.
So your body's saying, oh wait, I don't have enough water, reabsorb, and it overloads.
And it dilutes the blood that we just transfused. But then they get too much, then they become hypervolemic, and we have to give them a diuretic to get rid of the excess water. We want all the red blood cells, the white blood cells, the platelets, we want it to stay because we just put that in there, but we don't want all that extra plasma anymore. Okay?
Someone have a mic open?
Yeah, I think that's Enid's mic.
So why did they remove the plasma?
Case. Is it,
Why did they remove the plasma?
yeah, and would it be something where they got even more overload if they
That's right.
didn't do that?
That's exactly right. So Rachel asked, why do we pack the red blood cells? Why do we remove a portion of the plasma out of that unit? And she's correct. If we left the plasma and gave them what we call whole blood every time, a lot of those people would get into hypervolemia well a lot faster because that extra fluid they just would not be able to tolerate. Okay?
Just sitting there thinking, your body's sitting there going, okay, wait, I need more plasma, I don't want to need more plasma, but at the same time, you could say, well, if we provided the plasma, that it wouldn't need any, but I guess it's just going to keep absorbing anyway.
It's going to keep absorbing because of the protein content that's in that red blood cell and white blood cell. Okay, so those are the etiologies, the most common ones. Again, not the only ones. So what do we see when a person is experiencing hypervolemia? Well, we hear crackles when we listen to their lungs. We hear that pulmonary edema. Sometimes patients will tell you that they have a wet cough or a moist cough. Or they tell you, when I cough, I feel it rattling in my chest. Okay? Peripheral edema. Jugular vein distension. Let's see, where are we at now? We're back to Tonkwell, I think. Talk to me. What's jugular vein distension?
That's when your jugular veins on either side of your neck, you can actually see them.
Yes. So that's when the fluid volume has the vessels engorged enough that those large vessels, the jugular veins, are visible when a person is in a semi-Fowler's position. So if you'll turn to page 565 in your book, it describes how we assess for jugular vein distension. Be sure you're aware of that so that you can notice it on your patients. All right? So I'll give you a few moments to just glance at it. It was in your readings, but maybe you haven't gotten to it yet. Okay? Page 565, I believe. And just like weight loss represented hypovolemia, rapid weight gain represents hypervolemia. Those changes greater than a half a pound in 24 hours represents fluid gain. And then a bounding pulse. So again, somebody who has a healthy heart, you put more fluid into that vascular space, and those arteries are now engorged. So the amount of blood that heart ejects will be a larger stroke volume than normal, and it will feel like a boom, boom, boom kind of pulse. It'll bounce your fingers visibly on that person's wrist. Now, obviously, somebody who has hypervolemia and heart failure, it won't have the same effect. You're going to see that more through the jugular vein distension than the pulse. But a healthy heart is going to tell you in a bounding pulse that we got a lot more here than we need. Okay? Good question. The student asked, does hypervolemia cause arteries to blow out? The only time they do is when something called an aneurysm occurs. And you'll learn again about those in adult too. But that's a weak spot in the artery. Actually, that's not the only time. An AV malformation is another time. And again, you'll learn about that later. Okay? All right, so what do we do for these people? We're going to try to restrict their fluid intake. Again, we're talking about oral fluids primarily in this conversation. And so once again, we're going to try to set realistic fluid goals, but we always want to work with the client. Remember, they're autonomous. If we get them to participate, then not only do we get them well in the hospital, hopefully they will change their choices at home and stay well. Okay? So when we set a fluid restriction goal, you might see something that says 1,500 mils in 24 hours. And so as nurses, that means we have to divide that up between those 3 shifts. So typically, when we're talking about 8-hour shifts, on the 7 to 3 shift, you have 2 meals and your morning med pass. So typically, they get the largest percentage of that fluid restriction. So like if it's 1,200 meals, they might get, out of that 1,200, and this is just an example, they might get 750 of that, or they might get 650 of that. So more than half of it on that first shift. And then the evening shift typically gets about 1/3 of that amount, and then what is left is the lesser part of it that they might want to drink during the middle of the night or something of that nature. Okay? But make sure that whatever that fluid restriction goal is, that it is posted visibly for all of the healthcare team, and that the patient and their family knows what it is as well. Make sure they understand why this is necessary. And again, most likely it's due to a renal or a cardiovascular issue, and we're trying to spare them from dying from it. So make sure we allow in that fluid restriction enough water or enough fluid of some sort that they can take those oral meds. So helping them to minimize that allows them to be able to drink more at other times. If we provide small amounts in intervals, that's easier to deal with for the client, and it's easier for them to visually deal with it if we use small receptacles. So use a smaller cup rather than a big cup. Big cup looks very close to empty, where a small cup can look very close to full. Okay, so it has a psychological benefit for the client. Once again, if allowed for that patient, provide them their fluid preferences. So again, in this context, one thing you have to guard against is something that is high in sodium content because of what we said before. Sodium is the primary cause of osmotic pressure in the vascular space. So somebody who is hypervolemic, we don't want to increase their osmotic pressure, causing that problem to perpetuate itself. Ice chips are a good alternative to help them deal with the inconvenience of not being able to drink when they feel thirsty, because they will feel thirsty on a fluid restriction. That's part of the process they have to endure. But when we are counting it as part of their intake, it only counts for half of the fluid volume. So if you have 100 mils of ice chips, it's only 50 mils of water when we put it on their intake. Provide mouth care and rinses to help minimize some of that thirst. And try to involve the client as much as possible so that they feel like they're in control of the process, making sure that they understand that this is not punishment. This is not, well, you should have known better, but rather than let's help you get through this. Different perspective. Give me just a second, I want to see if I can go any further or not. Oh, the student asked a very good question. People on fluid restriction, do they have problems with constipation? Do they have to be on a laxative? There's certainly that possibility, but we can certainly use like a bulk-forming laxative that also will help pull fluid from the tissues into the bowel to be eliminated as part of the stool. The stool softeners like Electrolye, DocuSafe does that as well. Okay. All right, I think we are close enough to being disconnected. Does anybody have something different than 214? 214, does that sound right? Okay.
That's what I have in Tonkawa.
Okay, so during these last few minutes, very quickly, let me answer any questions that you might have up to this point. Not opposed to letting you out, but if you're walking away thinking, I have no clue what Mr. Baird has talked about for the last 2 hours, now's your window to ask the question. Okay? Yes. That activity page at the beginning, the things you're supposed to do to come before you come to class, it says bring a naturally occurring source for those electrolytes. You get to pick out which electrolyte you wish to bring, and then I want you to bring that to class on next Tuesday. So for calcium, for potassium, or magnesium. And even though it says optional on that page as far as the A&P review, I hope you understand from all the times I referred to it, that is a vital part of this lecture. And if anything I said during the lecture didn't make sense, I think it'll make more sense if you'll take the time to go out and look at that. Okay? All right, any other questions?
Yes, we have a question in Tonkawa. Hold on.
Okay.
Could the amount of plasma and the amount of salt used be equal or close to equal?
Okay, so you're talking about the hematocrit, and say that again.
Okay, so the plasma and the salt used, could they be equal or almost equal?
Do you want this
Yes,
puppy
when you
chow?
look up normal volumes,
Puppy chow, Hunter, I know.
it'll be slightly different for a woman than for a man. But for a man, it's 42 to 52%. That's roughly 50-50.